So, shall we start, guys?
Yeah, Saurabh, are we ready?
I think we are ready, isn't it?
Yeah, great, perfect.
Okay, we'll just. Okay, brilliant. Thanks, Rishi. Great lecture. Learned a lot. So next topic, guys, hand and wrist trauma. Arjun, will you switch off the lights, please? So following on to Rishi's lecture, so I'm going to cover the other topics. Lunate we have discussed, right? Can I invite someone to have a take on this? I'll take you through, promise. Switch the lights, Arjun. Very bright. So what do you see on our X-ray, guys? Or a radiograph?
So I think you've seen this before. This is a lateral plane radiographs. It shows a fracture of the various styloid. There's an abnormality where the lunation says, so this is a trans-radial perilunate fracture dislocation.
Fantastic. Fantastic. Perfect. In A&E, you will do all your open fracture guidelines for time's sake. So I'm just rushing. Investigation, what would you do?
I want to meticulously document my neurological and vascular status in specific median nerve because of where the lunate tends to sit within the carpal tunnel itself. And investigation-wise, once if I can manage to reduce it, splint it, and I want to get a CT scan
okay.
to assess any further osseous injury.
Brilliant. So you've done a CT scan, it's confirmed your suspicion, styloid and lunate. And then, so that's your lunate, that's your open fracture, correct? So what am I showing here? What am I doing here?
Doing an extended carpal tunnel incision. And the tendon that you can see is that your FCR tendon. Good.
So lunate is no longer seen, that means I've reduced it, yes? Where have I reduced it? Which space is that?
Space in.
Why is it a weak space?
It's a weak space because it's in between the proximal and distal intrinsic and extrinsic ligaments.
Extrinsic ligaments. V-shaped, centered over lunate and capitate. So good. And then K wires, you know, so we're not going to waste time on this, isn't it? Like we've done for all the ligaments. So you put your wires. Yeah, happy-ish. Okay, so what am I showing here? So I think it's 37 male, he fell down. So Galeazzi fracture, do we agree? Yes, because Drudge is all off. So see, Drudge again is hard to pick up, isn't it? A lot of times I have registrars in clinic come to me, even consultants, saying, oh, I feel ulna is out, head is out. What do I tell them? What do you think I tell them? All of them. Is it a true lateral X-ray of the wrist? Well, unless it's true, how do you know? So anybody can tell me what's a true lateral radiograph of a wrist? How do you know? When do you know it's a true lateral radiograph?
So in the lateral X-ray, there's a line that we need to check between the scaphoid and the.
So pisiform should superimpose on scaphoid tubercle. That is very important. Unless that is the case, I do not comment on Drudge, unless it's Bondo, like in this case. Yeah, because I can see so much radius angulation, I know ulna has to be out. Make sense? So please remember what's a lateral radiograph of a wrist, yeah, for you to comment on Drudge. Not a very good fixation, but in the sense, radial height is a bit, but it's okay, doesn't matter. At least ulna head is back in. So that's principle is, you will reduce, you'll put a plate on radius, and then ulna head should come back in, and you will check your rotations to make sure you got it right, okay? This is just a cadaveric dissection because I thought ulnar collateral ligament is important. So this is how, like I've been showing you scaphoid unit ligament, so, ulnar collateral ligament. Have you noticed they're pretty similar sort of width and how they look? So same, this is your UCL there, right? So they can show you a skier's thumb or a gamekeeper's thumb, normally a skier's acute injury. UCL is gone. Remember on our X-ray, if it's with a bone and it's undisplaced, you don't want to do a stress test because you can displace it and cause a stener lesion. Yes. So always ask for X-ray first, see if it's undisplaced, never do a stress test, put them in a scaphoid cast. If obviously there is a stener lesion, then you have to operate. Yes. So this was just to show you how UCL looks and the precaution you take in a undisplaced, avulsed UCL injury. Sagittal band, again, it can be traumatic or it can happen in your rheumatoids. This is just to show a video for you to make an impression of watch these two fingers, middle and, I think it's middle and ring, or is it index and middle? See how, now, see, can you see the extensor tendons falling into the ulnar gutter? Yeah? Yes? So that's a sagittal band rupture. And see on table, this is how it looks, sagittal band. And you have to repair it. The idea was to show you how clinically it looks, and you open it, that's your tendon obviously there, and then you repair it or reinforce it or tighten it. Yes? Make sense? This is the case we were talking about, distal radius plate. FPL will rub on it, and around 1 year, year and a half, patient will come and say, oh, all of a sudden I've lost my thumb IPJ flexion. Yeah. So in that case, you have to do a tendon transfer. So you need to know principles of tendon transfer. So normally I would take a FDS. So let's go through these operative pictures and see what we're doing. So that's FCR. Yes. Obviously you have to have a big incision because plate needs to come out. And then I need to take FDS to ring finger. So that's my ruptured FPL. Can you see? Compare this FPL now to the shiny FCR. So see how tendon lose their shape, their texture, their glistening surface. And we have other tendon transfers for Vaughan Jackson, which Miss Reichard and I did just 2 days back. So we'll show that also to you. But so it's gone. It's an attritional rupture, big gap. You can't do end-to-end repair. So I will show you what I did. So this is the first thing you do. The sling is holding the FDS to ring finger. When I pull on it, see finger flexes. I'm not holding the finger here. And I know it is not FDP because I can passively extend it. So I know FDP is not, it is pure FDS. Yeah. Remind me to check how you check FDS and FDP after this lecture. Clinically, we'll see. So once I know this is FDS and not FDP, then you'll take it off from A1 pulley. You'll take it out there, which I'll show you in the next picture. See, FDS I've taken out from A1 pulley. And then you take it under the median nerve. You don't want to compress the nerve. And normally your plate is there where my arrow is. But it's an attritional rupture. So your repair is not at the distal radius rim. It's further down somewhere here because there's a big gap now. Okay. So remember that point. And then if I take you to the next, see, that's where the weave is. Not over the radius rim, far down, 2 centimeters down. So it's a Pulvertaft weave. You can be asked, who can tell me what's a Pulvertaft weave?
Changing weave pattern.
Correct.
So split the tendon and then use the other tendon inside and take some turning sutures, turning stitches like that.
Correct.
Is that when there is a longitudinal traction, it will cause compression at the repair center?
Okay, good. Very good, Aarti. I always knew you will make a better consultant than me. So see, what you both of you are absolutely right. So you take a knife, you make an incision, you pass the tendon as Milindu said, and then you put a stitch, under maximum tension. So they will ask you describe Pulvertaft weave, because if you can describe it, you understood tendon transfer. So very important, Pulvertaft weave, yeah. And then you go at 90 degrees. So it doesn't matter. So easiest way is to show with a roll of paper. Do we have a roll of paper? So if we have a paper, you make it into a roll. If I make it into a roll, this is my tendon. You agree? Yeah. And let's say this is the FDS which I'm transferring, the thumb tendon. You take a knife, you cut, artery comes and my tendon comes down. Under maximum tension, you put a stitch. So you have to just go at 90 degrees. When I've gone like this, next lane can be this, come out, next lane can be up, down, or this way. Like you keep going 90 degrees. Stab, thumb, tendon comes out, stitch. And what you do is, after 2 stitches, you now need to, so once you've, so like in this picture, you do 4 weaves and 4 stitches, but after 1 or maybe 2 stitches, you need to check the tension. Have I built in enough? Because post-operatively, there'll be myostatic relaxation. Muscles will relax. So whatever I build in, it will relax. So if you see here, see, I'm not holding this thumb. Do you guys agree? And I've got very good flexion in IP and even at MCP. So I've really tightened it because I know this will all extend later. So you do 2 stitches, you check if it's like this, you're happy, then you do 4 weaves and then you cut the remaining tendon if you have any length left. Yes? So that's one thing. Second is straight line of pull. So remember my FDS is coming from here and then going like that. So I have to release my tendon through and through like any adhesions or anything so that it's in a straight line, not coming this and this. Because it should be straight line of pull. So this is what you mean by straight line of pull for your principle. Make sense, guys? And see what I'm doing here again. This is still intraoperative. When I'm putting pressure on MCP, if I do this, my thumb should automatically extend. It is still flexing. Yes, because I've got good tension. So now I'm happy that I've got enough tension. Make sense? And 3 months later, so you can see the scar, same patient. 3 months later, you see the, very good flexion there. Yeah. So if you build in enough tension, tendon transfers, good flexion will work well. Yeah. So that's your FPL for distal radius. Scaphoid unit we have covered is the same X-rays. You know that, you know this, you know the gilula lines, you know the Disc angle now. Do we agree? And again, same operative pictures. Yes. So retinaculum I've cut in my forceps. 3 bones I can see: lunate, scaphoid, capitate. That's my partial capsule flap, my Mayo flap, if you like, but you can say burger flap and make a burger flap. That's the scapholunate ligament. Again, you do joysticks, 2 wires, 2 anchors, capsulodesis, job done. This we have done, so I'm not going to even waste time on this. Tricuteral. Okay, so now lots of X-rays for distal radius. Are you guys, excuse me, asked distal radius in the exam, or is it or can you be asked? Okay. So see, as Rishi was saying, if you're shown a distal radius, it's not going to be a straight one. There has to be something going on. So for example, this looks fairly innocuous, but it's this step here I was a bit worried. And look at the dorsal tilt. So I said, okay, let's get a CT scan. And on the CT scan, as I've said, see the 3 slices. Volar cortex looks intact in all of them, correct? It's the dorsal fragments which have gone. Now, you could have done a dorsal approach, put a plate from there. Because dorsal approach has issues, I said, why not, in this case, go volar, like your tibial plateau. This wire told me where my step is. Can you see this fragment? Then I made a window, like your tibial plateau. This is a very nice accumate punch, and I'm punching it up. I've checked a volar plate. Yeah. So all I'm trying to say is, if you're shown a distal radius, it's not difficult, but there'll be something to think about. This is quite Bondo. There's a styloid fracture. There's a fracture dislocation here. You can see that, isn't it? What investigations would you do? You have to do a CT for anything complex CT. And you can see that scaphoid. So you can see scaphoid fossa fragment is very distal, very comminuted. Do we agree, guys? And then lunate. So lunate fossa fragment is all tending to come out. This is carpal instability. Adaptive lunate is adapting to the new environment, if you like. So it's all very distal and all very comminuted. Do you agree, guys? So I said, okay, I don't think I can put any plates to have some hole, dorsally, volar, fragment specific. I said, I'm just going to span it. Yeah. And because you give a plaster in a spanning plate, I left the styloid. You can put a screw, you can put wires if you want to. I said, okay, fine. It looks fairly undisplaced. So what am I checking in a spanning plate is the question, is the key. So one is my radioscaphoid joint. It looks parallel. Do we agree? It's out to length. I've maintained the space and I've not over distracted like in an X-fix. Because if you see my mid-carpal joint space and my radiocarpal space is fairly equal and maintained. Do we agree? And on a lateral also, I can see I've achieved my reduction and my carpus is back. Yes. And then these are your X-rays, 3 months. So plate will come out at 3 months, basically. So so there is a role of spanning plate. That's what I'm trying to say. And the role is when either with volar plate or dorsal plate or styloid plate, whichever plate, you cannot hold on to fragments. So if it's very distal and a lot of comminution, yeah. So if you're shown something like that, you can bring your X-fixes or infixes into discussion, basically. Again, you can see there's a bit of a step here. There's a bit of a dorsal tilt and a bit of a step there. Get a CT scan, isn't it? And if you see CT, look at any slice, this slice, this slice, this slice, all of them. Scaphoid fossa fragment, lunate. So I've shown all the fragments, like covered the whole 360 radius. Again, very distal. Do we agree? I felt, again, it needs a spanning plate. So I put it there. Yeah. So spanning plate does have a role. You will do 2 or 3 or 2 a year maybe, but you still do them. This we have discussed before. So who's going to have a go at this, guys? So this patient fell. And this was 2021, so it's fairly recent. So who wants to? I'll take you through it. This will give you confidence in exams. Okay, Kazi, go for it. So what do you see on an X-ray first?
So X-ray will have to be on the wrist, showing that there is the volar ribs of the distal radius seems to be fractured and comminuted. The carpus are not aligned with the distal radius. It's a volar pattern.
Okay, good, very good. So something is not right here, right? In terms of nerves, which nerve are you worried about? And why is that?
Because median nerve occupies the carpal tunnel and it forms the floor of the carpal tunnel. So any volar displacement will reduce the space.
Correct, very good. So let's say median nerve is fine. Fair enough, or not fine, doesn't matter. It can be dealt with in that manner. So now, what investigation will you do? Okay, so why have I put these slices? What am I trying to show here?
The level of comminution extending all across, including the styloid.
Okay, so let's look at the coronal CT, sagittal CT, beg your pardon, which is this bone. Okay, so which is this bone?
That's the distal radius
of lunate fossa fragment, isn't it? So that's your volar ulnar corner. That's the key. This you need to get reduced, otherwise we're in trouble. And axial cut, is this dorsum or what am I pointing to with my arrow? Good. So we know this is dorsum, that's volar, that's ulnar, so this is radial styloid. Comminuted? Comminuted? Yeah. So how will you tackle it? Like in terms of approaches, in terms of plates. So for volar Barton, for Smith, you put a plate from the front. So you're committed to a volar approach. If you feel styloid is comminuted, you can do a styloid approach as well. If you feel like, if you don't feel like it, don't do it. Put through some volar, see how it feels. Put some wires, do a hybrid fixation. There's no right or wrong. But this is how bit by bit you interpret your scans. axial cut in a wrist is very important. I don't know if your consultants have discussed that with you or not. The reason for that is you see your drudge, you see your ulnar head articulating with your sigmoid notch. So for example, in this case, this is my sigmoid notch is at least in 3 pieces. Do we agree? And if my this dorsal piece was sitting far up, it had displaced. And this piece was sitting far here. Then I'm committed to doing even a dorsal approach. Simple as that. So it may become a triple plating. So this is how you decide for your plates. So your best friends in deciding approach is your axial cut actually. Yeah. Look at this volar. So this is volar. That's your ulnar side, lunate side. Look at the volar ulnar piece. There's a step and it's sort of not sitting proper. And anyways, we know from there and from there. So axial cut in a wrist, very important. This approach we have discussed, radial styloid approach we have discussed, tips we discussed, isn't it? You hold the carpus and then do your 2 approaches and put your 2 plates, yeah? So the very act of surgery is easy. The journey to theaters and decision making is hard. And once you break it into simple steps, it becomes easier. Eventually it falls in place, yeah? Another volar button, even worse, see the carpus where it is, yes? Who wants to have a go at this? Anyone? Kazi? X-ray?
AP.
X-ray? Radiograph. Okay.
There is AP and
AP?
lateral
AP?
PA and lateral ribs
Good.
showing combinated distal radius and ulnar styloid fracture.
Good.
Uh,
What investigation? Is it what? Smith? Volar button? Colles?
Looks like a volar button.
Very good. Looks, it is volar button, sir. In exam for me, Saurabh, because then it gives you more confidence, yes? Good. So what am I showing on this coronal CT?
So it's a scaphoid fossa that's fractured.
Scaphoid fossa of radius. Okay, the radial styloid. Yeah. Does it look comminuted to you?
Yes.
Okay. What am I? We'll come to axial in a second. What am I showing on a sagittal? Which bone is this? See how far out it is. And it's trying to adjust. So see how it now extends. So this is carpal instability adaptive. Yes. So you know this is bad. And axial cut, why am I seeing axial cut, Kazi?
Decide upon the number of plates and approach.
Correct. So how's my dorsal fragment looking? Yeah, it looks, and is it articulating with ulnar head? So do I need to go dorsally? Good. So already I know is the volar ulnar corner is displaced, carpus is all out. I need a volar approach. And then I see the styloid is comminuted. I can do a styloid approach. Or if you think from volar plate, you can get screws or somehow get wires, don't do it. So this is how you decide for double platings, triple platings. Does it make sense now? Because otherwise it's very difficult to understand why are we doing double platings, especially to convince my lower limb colleagues. Same technique I had to do. I stabilized it with wires. Then I went from the front. Then obviously I've buttressed the whole thing. And then finally I put my styloid plate here. And look at the articular surface. Does it look reasonable now? And does it look reasonable there? And I've taken my wires out, see, in this frame. So, and now, like remember the diabetic patient where I had to put a wire from radius to lunate. Even at this stage, if it was subluxing, then I know the whole corpus will come in the front and this may fail. Yes. So then I may leave the wires for 3-4 weeks. So there's no right or wrong. What is right or wrong is your thinking process.
Just a quick question. Would you think about fixing the ulnar styloid because it's so low in this?
It's so undisplaced. I know TFCC is attached. I know it will heal up. I'm going to put this lady in a plaster because she started so I have not put this wire as a habit. This corpus, despite opening from the front, was not going back. So I had to really hold it with 2 stout wires. So I know I want these tissues to heal up. So this lady needed a plaster for 4 weeks. Normally with you don't give plasters. If it's a good stable fixation, 10 days plaster, pain, edema, swelling settles down, you get them moving, isn't it? So that's why you don't have to. It's a good question. And important to see at 2 months, it is this thing I see when I see my X-ray. I see nothing more for first 2 minutes when I see a patient. And luckily, screw is there. It has healed up nicely. It's out to length. Look at the ulno-lunate distance. It's there. There's been no abutment. Makes me happy. Yeah. So volar ulnar fragment is the key. Yeah. Take home message. This was again, it's okay. I don't have CTs, but I had done a double plating, a dorsal and a. So again, if I had a CT, I would have shown you an axial cut. If it was dorsal combination, then you go dorsal. Nothing, no more. There's nothing big in it. Now you know why double plates. Yeah, nothing big in it. This is important. 57. Who wants to have a go at this?
PAM lateral, which demonstrates a very distal intraarticular radius fracture with shortening.
Very good.
And, dorsal lesions with some dorsal combinations.
Very good. So see, that's dorsal combination. Exactly. That's dorsal combination.
Yes.
Look at where this fragment is pointing. Capsule is pulling on it, right? So is it a bad injury or not a bad injury? Significant, isn't it? Quite combination, quite this, quite that. I don't know what approach to do. I'm very confused still. So what investigation should I do?
Yeah, CT scan.
Okay, I've got a CT. Let's go one by one. Look at the sagittal CT. That's the volar fragment. That's the dorsal fragment. Is it big or small? Very, very small, isn't it? So it doesn't make me happy. I'm thinking, oh my God. Yeah, I actually am when I'm seeing it. Look at this. The shaft is plowed there. Look at the size of this distal fragment. Nothing, sliver or bone. Look at all the styloid is comminuted. So good or bad there? Still bad. So I'm still thinking, bloody hell, how will I manage it? Then I've done axial, not very good quality axial cut, but I've got it. Look at the space here, big translation, isn't it? This looks like some cortical piece there, high density. That's dorsal, that's volar with lots of soft tissue, that's blisters. And looks like the dorsal piece is displacing, isn't it? So God knows what approach to use now and what plate. So we can all work together, can't we? It's very distal. There's a lot of combination. Part of me is thinking, why not put a spanning plate from behind? At least this carpus will be sitting on radius. At least I can stretch it a bit without overstretching. At least my dorsum, this is dorsum will heal up nicely. But then I'm thinking, what do I do with the volar fragment? Remember, capsule was pulling on it.
Sandwich it together.
Correct. Then I'm thinking, can I do a sandwich plate, as our colleague is saying? I put a spanning plate from behind, then I open from front. It's a styloid fragment. I may have to do a styloid screw. I may have to, if it's unit also, I may have to do 2 plates. I may have to do 1 plate holding anything. It's the principle. So I'm thinking sandwich plate will be good, but with spanning plate, I have to take it out in 3 months. But I was within reason to do that. Somehow I decided, okay, fine, let's try a normal plating. Yeah. So fragment specific. So I went from the front. See, I'm holding styloid temporarily with wire. I went from the front. So I've got hold of my unit fossa fragment. For styloids, I've got hold of styloid fragment. And I was hoping, sorry, that when I do all this with a clamp, it may come back. I was hoping. And see what happened. So once I've done first plate, because this is your key fragment. So first plate, styloid plate, and then look what happened here. What's happening here after 2 plates when I saw the lateral? Yes, look at the capitate, it's still falling off because this dorsal combination is still out. So the carpus is still falling off. So then I was committed to do a 3rd plate. Yeah, it looks like, oh my God, right? But I was committed. So this is how you sequentially progress to triple plating, or I could have done a sandwich plate and then taken spanning plate out. No right or wrong. It's how you are interpreting your CTs and going towards double plate, triple plate. Is that quite okay? But see the 3 months, look at the movements. So I knew this patient may not do well. I've got 360-degree approach and 360-degree plate, and vascularity will be an issue. So I watched her. So I warned her pre or post-op. I said, listen, you may be in not big trouble, but if you're stiff, I may have to do capsular releases. So I said, you need to just see me for next 3 months, 6 months and follow as I tell you. And she was a very good patient. I'm sure I still gave her a plaster for good 3 weeks, not longer, because I have 3 plates now. And if you get them going and patients are compliant, you can see a scar on the volar side and the dorsal side. So you can get good movements. Yeah. It's the Kaplans we have discussed, volar versus dorsal. I like to put a wire in Kaplans, unlike PIPs. I'll just put a wire in 20 degrees MCP for 3 weeks and then I'll get them going. Yeah. What's this? Yes, parry lunate. Do we agree? Look at all the carpus. Yes. And something is happening with scaphoid also, see? So who knows, scaphoid may have, like you, again, doesn't matter, whatever it should. All I know is it's a significant injury. All I know is I'll attempt to reduce it in A&E. Make sure it's not open, obviously. Make sure median nerve and everything is fine. But get a CT. But why I have put this slide here is to show you one thing. So who can interpret these wires for me first? One by one. It's easy. So see, if I go take you back so that you can't say I'm tricking you, lunate, whole carpus is out. So which ligaments are gone? Scapholunate and lunotricutal, that's why whole carpus will be out. So what are these two wires doing? Scaphoid to lunate and scaphoid to capitate. And what are the other two wires doing? Which is the bone next to lunate in the tricutum. And what are the anchors doing? These anchors in the carpus. Anchors are wherever, scaphoid, lunate, tricutum, doesn't matter. They will be there. But why are they there? To slap the capsule down, which is known as washing line technique in capsulodesis. The reason I put these two anchors was the dorsal capsule had completely lifted off and I wanted it to slap back and heal up. So I put an anchor there also, doesn't matter. But what happened was, see KYS, infection went and see now it's totally infected. Can you see the bones are all going? So they can show you this and then you have to talk about MRIs and debridements and micro and antibiotics, all that jazz, yeah? This was the one I discussed with Ms. Reichart. And yeah. So, okay, what is this injury, guys? Look at this, I magnified it. Pilon type, isn't it? So you can be asked that classification when you have that volar base middle failings. If it's one big chunk, you reduce and put a wire. You can put a screw from the front. If it's pilon type, then you have to do what? Okay, so we have done that. Ligamentotaxa. This Miss Reichart and I did together, I remember. So look at the joint space. So we did distract it nicely. Fine, it all healed up beautifully. And then pilon type, anywhere in the body, arthritis and pain. In PIP, what are the options?
For the arthritic.
Now it's arthritic and it's painful. Okay, so what are the options? You can fuse it or replace it, isn't it? So Ms. Reichart replaced it and he's doing very well. Okay, so PIP replacement, and if you see carefully, it looks like a knee joint, isn't it? It's twice as expensive. Yeah, I mean it. It is. So we are posh hand surgeons, you see. So replaced it basically, yeah. So you've seen the whole journey now of PIP injuries. What's the worst? Arthritis will happen. You can fuse it, replace it. What can you do? Yeah. Both bones, 10-year-old. So how will you manage? There are no tricks. These are all my x-rays. This is what you get in DGH. This is what you will get. All done, sir. Final operation.
So I would consent, I would do a try close reduction and manipulation under anesthetic. If that works, I would put in flexible intermediate nails.
Okay, why can't you put plaster in this? Simple plaster. So why can't you? You may be right, you may be wrong.
The fracture is at the same level, so that led me to think that it's unlikely to be stable.
Good, so that's one answer. Second, look at this bone. Is it displaced, not displaced? Correct. So even if you get perfect reduction by manipulation, chances are it'll displace. So that's why. So in exam thereafter, your thought process, you may still be, someone may have gotten away with plaster, who knows? My thought process in exam is same level, unstable. This is all displaced, almost 80-90%. I feel it's going to displace again. Periosteum has memory. I want to put something there and I'm going to put elastic nails. Yeah. So unless you say with a bit of surety, they will confuse you, or they'll say, oh, he's not that confident. Yeah. So we've done elastic nails. Yeah. How will you critique them if I was to ask you? This has healed, obviously. It's a healed one now. You know the alignment is fine and the bones have healed and sort of there's a good interosseous space and all that. So that's all critiquing. Main is wire. It should be enough out here and enough out here for you to take it out. Yeah. And it should traverse the whole length. It shouldn't stop halfway once. Sort of it should go enough. Otherwise they become loose and start backing out. So you can critique anything in any way, isn't it? Has the healing happened? How's the angulation, interosseous space? Are the wires adequate length? Make sense? Ah, that's a good one. Who wants to have a go? I put the answers for you. I'm nice. Because you guys can give me some of your pizza. Good. So it does happen, isn't it? Fourth, fifth. We all see it. Okay, what's this? Which bone? Hook of hamate, yeah? So which is this metacarpal? Fifth or fourth? Fifth. Hook will be fifth. Yeah, that's how I know it's fifth. So this will become fourth. Yes? So you can see fourth and fifth, they're plowing into hamate and see how they've caused a fracture. What will you do for this?
Reduce and fix good CMC joint, and then ideally you need to fix the hamate.
Good, very good. So how will you deal with your, let's say it was a pure, so we'll break it into simple steps. There's a hamate fracture, there's a fourth, fifth dislocation. Let's say if it was a pure 4-5 CMCJ dislocation, which you see all the time. How do you manage those? So you reduce it. It's reduced now.
Stabilize with the 2K wires.
Okay.
Some use 3K wires, but I tell this is 2K wires.
Okay.
And one go
So which is the order of your wires now? Where will your first wire go? Where will your second wire go? And why?
first wire is the proximal one.
I don't know. You described it to me.
So first wire is the proximal, which goes from so I will make sure that the solution goes somewhere like this, and to make sure that it's protected. I make a so the solution
Cutaneous ulnar nerves are on the dorsal. So wires have to go from the side. Right. You don't want an issue for the wires. You agree? Okay. Good. Where is the first wire going? Where is the second?
So the first wire, what I will do is go from the base of the fifth until to the hamate.
Okay.
And then second wire from the fifth metacarpal to the fourth metacarpal as well, and then come and drive into the carpus bone as well, depending on the stability.
Okay, drive into the carpus.
I mean the capitate.
Okay, so second wire goes there, and since you love your wires, take a third wire now. No? You're happy with 2 wires?
2 wires.
Okay, anybody wants to
And
have
I
a
need
go?
to take a proper lateral view before.
They're gone beautifully, very important. They're gone. They are in hamate and capitate. Anybody wants to have a go? It's just wires.
Fifth metacarpal into the hamate.
Very good.
The second I will base from the fifth metacarpal base into the fourth metacarpal base.
Not getting this, I will get the answer. No,
Or you could go for the second, so from the fourth base into the
out there. So exam is not difficult. If I was taking exam, I'll ask you to do stuff. So any other takers? It doesn't matter. Yes, or yes.
It's a just pure dislocation of the fourth and fifth. If you
Pure
go
dislocation.
pure dislocation, then it's the first wire from the base going into the metacarpal into the carpal bone.
Okay.
And the second wire would be the tough wire, is the fourth metacarpal base going on to the carpal bone. The angle is very difficult to reduce. Get it, but that would be the
Any
second
other
wire.
takers?
I think both the wire has to go through the fifth metacarpal. The first can incorporate only the hamate. Second has to
So
incorporate the
first wire from base of fifth
to the hamate.
to the hamlet. Second,
Second, fifth, incorporating the fourth going to decapitate.
fifth, fourth capital, right? We will do. Any other takers?
And then we have to check lateral view.
It's gone beautifully answered. For that I always give. I never say it's gone anywhere. I'm that way very generous.
wire across the bases of the fifth, fourth going to the third.
So your first wire is
And also the first one is from the fifth
in
into
the
the
hamlet.
hamate. The
Second.
second one just across the bases to the third.
Fifth to the fourth to the third. And why is that, sir?
Just to fix it, because those are the ones that are dislocated. To transfix fourth as well. To the third,
Okay,
because the third is not dislocated.
true. Agreed. Any other takers?
You mean fourth also dislocated?
Don't do X-ray. Nothing mobile.
We fix the mobile race to the fixed race.
Any other takers? Okay, so if I were to say you're partly right, otherwise it's not right. And I'll tell you the reason why. And let me show you. So see, I'll try and, okay, let's see this picture first. If I was to put the first wire from fifth to the hamate, yeah, how can that wire maintain this joint space? Yeah, so your first wire has to be a distraction wire. Same in Bennett's. First wire goes from first to second to distract the joint. Second can go into the trapezium. Remember that, yeah? So your first wire has to be a distraction wire. And if you're putting just wires from fifth to hamate, fourth to capitate, yeah, fourth to hamate, your joint can still do this. Remember with your nailings, one screw is not enough. You put two, isn't it? Even two, they say it allows some movement. So first wire has to be from fifth, because fifth and fourth are gone. So I have to, as you said, but your first wire is this, into the third, because third is your solid one. It will keep fourth and fifth out to length. Even with one wire, my fourth, fifth can do up and down. Do you agree? That's why I put two wires like this. Yeah. Once my two wires are there, distraction wires, this joint space will be maintained. And remember, once fourth and fifth reduces, it's a stable joint. It's not now going to sublux. If you are worried, you can put your third wire from fifth to hamate, and it will lock your fourth in if you want to. I was not worried. Make sense? And then you open dorsally, you protect your cutaneous nerve, as Milindu said. And what am I doing here, Milindu? Where is the screw going? What's the structure? Hook, and hook is under fifth. Yeah, that's why I was saying fifth. So I know I'm right in the middle of the hook. Then you do 5, 6 images. I've just put 3. You rotate slightly oblique, and then a proper PA, whatever. Why am I showing this view? End on view of screw. What is this? Anybody? What is this structure? So I know I'm right in the hook. Why am I so concerned about that? Yes, ulnar nerve is in the front. So when I was drilling for a screw, if I was not in the hook, I can wrap the nerve. I can damage the nerve, right? So that's why you do a lot of views. And this is how it looks, yeah? So remember that.
Even for isolated base of fifth, fourth, you still recommend this type of.
Because you need to maintain the joint space. That is more important. So this is your mobile column 4, 5. Yes. Why is that important? Why has nature given us a mobile column? Correct. It gives you grip. Grip comes from these two fingers, isn't it? What happens if I get properly? Then how do you deal with it? So this joint space is not good. Patient has arthritis. He's come to you a year later. Joint is reduced on a CT or waves on arthritis. He's in pain. What do you do now? So first, second, third were rigid problems. If there was problem between capitated and metacarpal, you say nothing, sir, I'll fuse it. Problem with trapezius metacarpal, nothing, sir, I'll fuse it. And fourth, fifth problem is a mobile column. There's a lot of movement in that joint. You can't fuse it. So what do? It becomes an issue. You have to put ECU there, or capsule there, or some tissue, soft tissue position. So that's why you want to avoid arthritis in profile. That's why distraction wire is very important. Yeah. Same with your Bennett's and Rolandos. Yeah, maintain the joints with distraction wire. I've just put some. Shall we have Rishi?
Yeah.
Do you think we should have lunch? Because
Let's
it's
have
get
lunch.
cold. Then I'll finish these 3-4 slides and a bit of drawing on the paper. Shall we do that?
Yeah.
Brilliant. Let's do that. Is that okay, guys?
Yes.
Any questions? Sorry, first of all.
You get the lens side, but still the DRUJ is not relocate.
DRUJ will always relocate if your radius going is okay and you got it right. 100% okay. Unless it was a big dislocation and your ECU has flipped in or some soft tissue, which is very occasional, but you will know because you have seen so much displacement, then you are thinking of it and then you flip it out.
How do you approach the DRUJ?
So it depends. Rishi has one very good Excel to show you. If your Drudge has, so if your ulnar head has come out dorsally, then when you supinate, it tends to fall back in. Yeah. If your ulnar head has come out volar, which is Rishi's case, pronate and it will come back in. If there's any interposition, you go through the bed of, so normal approach to fix TFCC is bed of EDM, fifth compartment. Go to EDM, cut the retinaculum, EDM goes to bed. Let's say ulnar side, make sure you don't cut the TFCC, then open the capsule, and then whichever, you can just reduce it. Makes sense? If you got KYS, no. If at all you have to put a wire proximal to Drudge, and make sure the wire, if you're going from ulnar, comes out of break so that if it breaks. Normally, Drudge doesn't need wires. Once you've reduced it like PIP, it's very stable zone. Yeah. Drudge is a very hard problem with wrist, but they will not, don't put wires. Just say above elbow. You do sugar down also or above elbow. Any other question?
When do you remove the K wires in CMC dislocation? 6 weeks.
6 weeks. Wires are not easy. Infections happen. I'm most worried about wires. So with wires, you have to constantly tell patients, no sweating. When young men, they go out, they sit in pub and they sweat. And this is what happens with wires. Because infection will go in right into carpus and then you're done. So you watch wires like a hawk yourself. Don't trust so much. Sometimes you can bury the wires. They say after 4 weeks there is evidence that infection goes up quite a lot. So after 4 weeks, they say if you have to do wires, just bury them under skin. Better to take them to later than they are. Don't do it, but this is.
Sorry, 2 questions about tens there. Now, but asking the right question. You usually remove them in 6 to 9 months. It's
3 months patches here.
And then the question I have is KYS we keep for 6 weeks and then we remove it. But then the tens then intramedullary we keep for 3 to 6 months. And what is how does basic science wise
Consolidation, let it consolidate as soon as it can.
and then when you remove it, the intramedullary still have time to heal, isn't it? Because intramedullary it's kept right by the metal.
What has to be there?
I mean, what's the
Bone will consolidate
from there?
Consolidate.
Yeah. So when you remove the intramedullary foreign body, it will take time to heal as well, isn't it? To protect
To
you.
damage any endosteric blood supply,
Yeah.
just go back to the concept. Yes, enough periostic blood supply. That's the spanning plate comes up at 3%. 3% roughly time to 80% there. Sorry, how will you reduce flexion type? What will happen in flexion type? It's come forward, isn't it? You just extend from the front. What will be the
pronation aspiration?
That's to do with the wheel combination. Wheel combination is exponential, or the supination. Supracondylarus, Gartman 3. Anything which is 100% distal, anything body, there's a lot of soft tissue from communication, soft tissue injury. By and large, they should almost always reduce. You should almost never have to open a supracondylar Gartman 3 unless there's a pucker sign, unless they have really massively displaced muscles or something.
More approach or
I do a medial approach. Exam answer is that approach. Only because I have to see underground anyways. So then I'm even more safe, happy to see my Bondo in clarity and one incision job done. Exam answer lateral approach. I do 3 KOS. And I can convince all of you that 2 hours are not good. For the exam, Deborah Eastwood is also very well. She has 3 wires.
I mean, the advantage is you can take my count.
Also, correct. For many reasons, totally right. For many reasons. But to convince you guys that 3 is better. But for exam, 2 hours. I don't think but exam answer 2. Try and show your knowledge and even prove it. They will think he's adventurous, he will do 10 more things. Very simple, humble. And do what you want to do. But yes, 2 hours, for example.
When you condyle fractures, it's not displaced. You manage them every week.
I have that in contact. Bring all your questions actually.
Yeah.
There are a few things. Set of things.
Yeah.
Thanks, guys.
There's chicken and veg. Which
There's no pork or beef.
Someone's mask is here.
Saurabh?
We are having a lunch break, sorry.